Hi, this is Dr. Lazaire again. Now I'm going to be talking about assessing pregnant women. A lot of things change during pregnancy, and when you're doing a physical assessment, it's important to understand the physiological, anatomical, and emotional changes that occur so you can do a good exam. We're going to talk about the anatomical and physiologic changes, the importance of risk assessment, physical findings and tests done during OB visits, and ways that pregnancies are dated. One thing that's important during pregnancy is always be assessing risk. Activities that confirm the presence or absence of medical and psychosocial risks prior to or throughout pregnancy can be found out through the history, the physical exam, lab tests, nutritional surveys, and histories of obstetric and genetic factors. Psychosocial risks need to be addressed. They can include social issues. It's important to determine if someone is a victim or has been a victim of intimate partner violence or gender-based violence. Financial, do they have what they need to bring a baby into their life and to pay for good nutrition during the pregnancy and prenatal care? What's their insurance status? What's their environment like? Do they live in an environment where there's not heating, or maybe there's roaches with droppings? These are all important issues. What are their habits? Do they smoke? Do they use any kind of drugs, legal or illegal, that might cause harm to the fetus? All of these are important to assess. Early and continuous risk assessments vital. Each time you notice something that's a risk, you should note it and keep it on the problem list until it's resolved, and update the problem list at every visit. Health promotion of pregnant women is always important. It's a normal physiologic life cycle event, but it's one with a lot of changes and challenges. And medical and psychosocial interventions are important in follow-up. Now, some terms for you. You've probably forgotten these. A zygote is a fertilized ovum, and up to 2 weeks, it's called a blastocyst. At 8 to 12 weeks is an embryo, and 13 weeks to term, we call it a fetus. After it's born, we call it a baby. Okay, so this is a chart that I refer to a lot when I'm thinking about teratogenic insults, meaning something that causes birth defects. And you can see that there are different times when different parts, organ systems are being developed. And even after organogenesis, which is the first trimester for the most part, there's effects that happen, like the teeth, the eyes, CNS, external genitalia, etc., that can occur through term. So it's very important for women to continue to be vigilant about avoiding any kind of practices or medications, etc., that could be teratogenic or cause risk to the fetus. Okay, so confirming pregnancy. Of course, the human chorionic gonadotropin test that we use to confirm pregnancy. It's measured 4 weeks after the first day of the LMP, and you should use an early morning sample so it's concentrated. Serum pregnancy tests are more accurate, more sensitive and specific. They can be measured before the period is even due. Your book says they don't need to be used, but oftentimes they may be in various situations. Okay, so signs of pregnancy. All right, so you probably way back remember this, that there are presumptive changes, probable changes, and positive. Presumptive is changes felt by the woman. Probable are changes observed by the examiner. And positive are signs attributed only to the presence of the fetus. So there's only a few of them. They're the only ones we can say, yes, that means you're pregnant. Okay, so here's cervical changes. There's Goodall sign, softening the cervix, see in the second month. Then there's Chadwick sign, which is the blue-purple discoloration of the vaginal mucosa, you see in the 4th week, and Hager's sign, which is softening of the lower uterine segment, seen at 6 weeks, and this can be palpated by the examiner. Here are some signs of pregnancy divided between presumptive, probable, and positive. Take a look at these. You'll see that the only positive are the sonographic evidence, fetal heart rate being audible to an examiner, and fetal movement felt by examiner. The rest are either probable or presumptive. Say something like a positive HCG test can be caused by certain kinds of cancer. Nausea and vomiting can have other reasons for that to occur. Even quickening people can think that's it could be attributed to gas. Okay, so here are uterine sizes via weeks. The uterus starts out in a non-pregnant woman about the size of a lemon, increases all the way up to the 40-week mark. Of course, about towards the end of the pregnancy, the fetus kind of drops as it becomes engaged. But this is just an idea of what you should expect in terms of uterine growth. Uterine size can be compared to tennis balls or sports balls and fruit. 8 weeks, it's a tennis ball or an orange. As I said, the non-gravid's a lemon. 10 weeks, a baseball. 12 weeks, a softball or a grapefruit. And 16 weeks, halfway between the symphysis pubis and the umbilicus, is where the fundus should be felt. And at 20 weeks, it's at the umbilicus. Vaginal changes include epithelial hypertrophy, increased vascularity. Hormones prepare for stretching during labor and delivery. The leukorrhea, increased white blood cells, causes a whitish normal discharge. So pregnant women may complain that they have more discharge than they're used to. And the pH of the vagina is slightly acidic compared to non-pregnancy. The breasts, of course, become fuller. They become more sensitive. Women may experience tingling. There's hypertrophy of the sebaceous glands. There's venous congestion. The breasts enlarge in size as the glandular tissue is getting ready for lactation in the second and third trimester. Colostrum may, in some women, be expressed after the 12th week. That's the yellowish foremilk that we see before the milk comes in. It's full of antibodies. Stria gravidarum, stretch marks, may in some women be seen, not always. Areola darkens, and you can see a picture there to illustrate that. Respiratory changes, for the most part, the respiratory rate stays about the same, but as the pregnancy progresses, women go from being abdominal to breathers to thoracic breathers because of the fetus pressing on the diaphragm. Cardiovascular changes, you see a heart rate increasing 10 to 15 beats per minute. The blood pressure in the first trimester is pre-pregnant level, and it is also goes back to that in the third and the second trimester. The blood pressure should decrease. That's due to decreased peripheral vascular resistance that occurs. If you see the blood pressure is not decreasing and is increasing, you need to consider preeclampsia. Cardiac output is increased from 30 to 50%. Blood volume increases by 1,500 mils or 40 to 50%. And the white blood cell count goes up as well, increases in second and third trimester. And during labor, it can be as high as 19,000, and it's up in early postpartum too. That's normal. The S1 heart sound is often louder. You may hear physiologic ejection murmurs. These are innocent murmurs, but anytime you hear a murmur during pregnancy, you should have evaluated. And there's left axis deviation. Now, vena cava syndrome, any OB nurse knows about this, or anybody who's been pregnant. If you lie on your back, blood pressure can drop, and you can have dizziness, pallor, clamminess. So pregnant women should not lie flat on their back. They should lie on their left side. Anemia. So anemia does occur in pregnancy, but there's a physiological anemia of pregnancy. So you want to have a hemoglobin 2 standard deviations below the mean for that to be considered anemia during pregnancy. The physiologic anemia of pregnancy, which is due to the hemodilution of having a greater increase in plasma versus erythrocytes, is normal. Actual anemia is seen in 15 to 25%. of all pregnancies. It's defined as less than 11 hemoglobin in the first and third trimesters, less than 10.5 in the second trimester. Gastrointestinal changes bring a lot of the complaints of pregnancy. Of course, in the early days, the human chorionic gonadotropin can cause morning sickness. Usually it stops at the 12 to 14 weeks. It begins around the 4th week. This can be increased in the second or third trimester. Not everybody, appetite increases in the second or third trimester, but some women continue to have morning sickness throughout the pregnancy. There's changes in sense of taste and smell. Women may have food cravings or find smells that really just make them sick. When I was pregnant, I remember where I worked, the hospital cafeteria smell just made me sick. I don't know what it was. Only felt that during pregnancy. Pica, ingestion of non-food items, sometimes chewing on ice, cornstarch, all kinds of things can be a sign of anemia. Pedalism, which is excessive salivation, is normal, and decreased GI motility, of course, leading to constipation, which is a common pregnancy complaint. Now, the renal and urinary tract changes in pregnancy are legendary. The bladder capacity increases to 1,500 milliliters. GFR increases. Renal plasma flow increases. There's increased frequency, particularly in the first or third trimester. I think in the second too, in reality. But in the third trimester, the baby's sitting on your bladder, and women complain a lot about you go to the bathroom, as well as the first related to hormonal changes. Pressure changes can impair drainage, and there's increased risk for infection. UTIs during pregnancy, they're really common. They may be asymptomatic, and it's important to assess for that, because any infection can cause preterm labor. There's a lot of skin and hair changes, much to most women's chagrin. The Chlasma mask of pregnancy is shown in the bottom of the slide. Usually goes away after pregnancy. Linea nigra, that's that line, midline line that occurs in pregnancy. The striae gravidarum, stretch marks. Palmar erythema, gum hypertrophy occurs. Real important for pregnant women to be visiting their dentist and taking really good care of their teeth during pregnancy, and vasculospinal nevi, or at least some of the many changes that can occur. This is by no means an exhaustive list. Skeletal changes, the center of gravity shifts. We've all seen the pregnant women, the waddling gait. There's relaxation, increase in mobility of pelvic joints. And that picture there is diastasis recti. That's where the abdominal muscles sometimes separate. It really scares patients. It's not the end of the world. It usually takes care of itself after pregnancy. Within a few months, it repairs itself. If not, it can be repaired. Okay, there's a lot of metabolic changes. Base metabolic rate raises by the 4th month, increases 15 to 20% by term, and returns to non-pregnant levels 5 to 6 days postpartum. There is increased fluid retention. The thyroid has moderate enlargement, and the parathyroid does as well. Glucose metabolism is changed a lot during pregnancy because you're meeting the needs of a fetus. There's increased glycogen storage, increased peripheral glucose utilization, and enhanced hepatic glucose production. Increased free fatty acids and ketones exist during pregnancy. Now, we don't want ketones in pregnancy because it can lead to CNS problems for the developing fetus. So that's not something we want to see. There's an increased insulin response to glucose. And in late pregnancy, there's increased insulin resistance, higher postprandial glucose values, and the fasting state decreased glucose values. And that's why sometimes pregnant women faint, because they can be hypoglycemic. It's not just something they made up in the old movies. Hormonal changes, estrogen and progesterone are elevated. That's produced by the corpus luteum in the ovary. At about 14 weeks, the placenta takes over. The estrogen and progesterone suppress the FSH and LH by the anterior pituitary. Look on page 927 of your text for a discussion of the effects of estrogen and progesterone on pregnancy. Human chorionic gonadotropin, maintains production of estrogen and progesterone by the corpus luteum until the placenta takes over that function.